Hi, everyone. I'm Karen Lee, Director of Health Economics at Canada's Drug Agency, and I'll be moderating today's lecture, the first of our 2025 lectures, and for that matter, the first of our lectures as Canada's Drug Agency. This is a hybrid session with some in-person and some online attendees. And from what Peter's told me, currently we have over 900 registrants for this lecture, so that's wonderful. Some of us have gathered here in Ottawa, Ontario, Canada, on the traditional unceded territory of the Algonquin Anishinaabe people. And I would like to thank them for caring for this land for thousands of years. And I would encourage everyone participating today to think about the land where you live and work, and to give thanks to the people who have lived there before you and still live there. We've been presenting free lectures by prominent scholars and opinion leaders since 2014 as a way to highlight key topics, discuss pressing issues facing health technology assessment and healthcare today. We like to invite the recipients of our recognition awards to deliver lectures, and that's the case today. Dr. Doug Coyle is Professor Emeritus at the School of Epidemiology and Public Health at the University of Ottawa. He also received the 2024 recipient, or he's also the 2024 recipient of the Dr. Jill M. Sanders Award, which recognizes career achievement in health technology assessment. Throughout his distinguished career, Dr. Coyle has become a pivotal figure in fields of health economics, as well as health technology assessment in Canada, as well as around the world. His innovative research has provided important insights into cost effectiveness of healthcare interventions and has informed a wide range of policy decisions. He was an active member of the group of experts who helped develop our Canadian health economic guidelines, and he served on various provincial committees in Ontario related to the evaluation of drugs. The focus of Dr. Coyle's lecture today is on economic evaluations, what they are and what they aren't. Recent debates have raised questions about the role of economic evaluations in shaping reimbursement decisions, often fueled by common misconceptions. In the next hour or so, Dr. Coyle will provide an insightful exploration into the true purpose of economic evaluations, a thoughtful debunking of common myths, and explore how economic evaluations serve as critical tools to empower decision-making to drive better healthcare outcomes. Excuse me. Before we get started, and I hand things over to Doug, a few logistic announcements to make. The recording of this session will be posted to YouTube later this week. We will also post a PDF of our slides. And time permitting, there will be a QA session after the talk. Those of you attending in person can raise your hands and I'll recognize you, and you'll just have to turn on your microphone so that the online audience can hear you. Online attendees can enter their questions at any time in the QA function on the Zoom platform. And we'd ask that everyone asking questions identify themselves and the organization. And with that, I will turn it over to Doug.
Thank you, Karen. Thanks for everyone being here in person and all of you online. I would try and imagine there's only 3 of you and not 900, just to make it a little less stressful. So what I'm going to talk today is I'm going to give a very brief introduction to what economic evaluation is, and then I'm going to discuss 7 of the issues that have come up with respect to its use in decision-making, and try and address those issues and try and clarify my position on those issues, but also, I think, maybe enhance the value that economic evaluation can have in decision-making. So when I lecture, or at least should say now I'm retired, used to lecture postgraduate health economics students at the University of Ottawa, and the first question I'd always ask them is, what is economics? And I won't ask the audience today, because hopefully most of you know, but the answers I'd get are things like stocks and shares, investment, inflation, the economy, gross domestic product, all of those types of words that you hear when you hear the media talking about economics. And it's safe to say that I know very little about any of those topics. So that is not what economics is. So economics is not about costs, and I think that's what everyone seems to think about when they think about how economics is used in decision-making and what economics means, but none of that is what we're actually interested in. Economics is a study of how choices are made, which is positive economics, or how choices should be made, which is normative economics. And basically, it's how these choices are made because we have scarce resources and we can't meet everything that society wants or needs. So health economic valuation is simply a tool to help decision makers make these very difficult choices, because at the end of the day, in all our lives, in all our situations, we have to make choices because we can't do everything. We can't always get what we want. And therefore, what we need to do is find an appropriate way to make those choices. So hinging around that idea of choice gives a concept that really underlines all of health economics, which is that of opportunity cost. If we spend more on one thing, we have to do less of something else. That might be that patients are denied treatments that they might normally receive, or it might be that patients have to wait longer to get surgical interventions, testing, see a family physician, etc. But every time we spend more on one thing than we did previously, it necessarily means we have to spend less on something else or delay that spending. Opportunity cost, therefore, isn't about the dollars that we're spending on the new interventions, but it's about the health that's going to be denied other patients because we can no longer afford all the technologies that we used to afford for in the same timely manner than we did previously. So the value of a new technology is the health that it gains to those patients it receives, less the health that is lost from those patients who are denied the previous type of service or care that they received before this new technology was funded. Now, economic evaluation is rooted in the assumption that one of the objectives of the healthcare system and the decision makers who make these decisions within the healthcare system is to increase the health of the population. And therefore, what we do in economic evaluation is identify if a new technology will lead to greater gains in health than the interventions that can no longer be afforded or denied to those patients who are not receiving this new technology. Now, economic evaluation is not a decision rule. Economics itself doesn't determine whether or not the new technology should be funded, because there's clearly other criteria that are important to decision makers. Could be concerns over the distribution of health, who benefits, the nature of the disease. There may be specific diseases that decision makers want to prioritize, or it could be specific population groups that decision makers want to prioritize. So economic evaluation itself doesn't give an answer. We don't say whether or not a new technology should be funded. All the economic evaluation can do at the end of the day is tell you whether or not funding the new technology will lead to greater gains in health or less gains in health. And that's all we can do. Does the new technology funding increase the health of the population? So economic evaluation is simply a way of assessing the long-term costs and benefits of different ways of treating a specific patient group. And typically, it should be designed to address a specific problem a decision maker is facing. So in other words, should a new technology be reimbursed or not? And we assess cost effectiveness simply on the basis of, does the overall health of the population increase if we fund this new technology? So we look at the costs, the value of the extra resources used, and the value of the health gain, the consequences to the particular patient group. But what's important is those costs can be expressed as a health loss to other patients who no longer receive the care they will receive if we divert resources from one technology to another technology. Within economic evaluation, we need to know quite a bit of different types of data. We need to understand epidemiology and treatment effectiveness. That's why a large number of health economists are based in departments of epidemiology at universities because we need to have that understanding of the natural history of disease. We need to be able to assess the quality of life impacts of interventions, utility values, and also the costs of resources associated with disease and the costs of treatments themselves. Now, the biggest drivers of results and where the biggest uncertainty about whether or not a treatment is worthwhile is the epidemiology and the treatment effectiveness. When we measure or assess cost effectiveness, we measure the impact on costs and we measure the impact on health-related quality of life and life expectancy, or QALYs. Epidemiology and treatment effectiveness affects both of those measures, while costs and quality of life only affects one. So therefore, the biggest drivers to cost effectiveness relate to the epidemiology and treatment effectiveness. In economics, we typically have to use models, and that's because of the short-term nature of the clinical trial data used to inform whether or not in an ideal setting a treatment will be effective or not. We need to use models to interpret these clinical results into real-world practice. We need to use these to measure long-term patient-related outcomes from often short-term clinical markers of health status. And we have to incorporate all outcomes relevant to patients, such as quality of life. So models in economic evaluation are important, if not fundamentally necessary. They are simply representations of our current knowledge. So it's taking all the data we have available relating to a specific decision and combining these through a series of mathematical relationships to estimate the long-term costs and benefits of treatments. So I'm going to show an example of a study that I worked on with colleagues mainly in Toronto, relating to advanced pancreatic cancer, looking at systemic therapies in that disease. This is a type of data that we'd require. We've got the data on the epidemiology and treatment effectiveness. We've got the utility data and the costs associated with the different states patients can be in. Oops, gone too far. Why is that not going backwards? There we go. We develop a simple model to model what happens to the population over time in terms of moving from the progression-free with and without side effects to post-progression and ultimately to death. And we estimate the cost effectiveness of the treatment. So that's basically this fundamental components of an economic evaluation. And we can see in this example for Firenox versus gemcitabine and 5-FU, I think I've got those names right, we assess the long-term QALYs, we assess the long-term costs. This is the disease where long-term, unfortunately, is fairly short-term. And we can assess the incremental costs, the incremental QALYs, and what's important here is the incremental cost effectiveness ratio. And we come up with an answer, which is for every QALY gained by giving FOLFIRINOX rather than gemcitabine and 5-FU, the cost is $30,666. And that's the result of an economic evaluation. It doesn't tell you what to do. All it does is tells you how much we have to spend for every QALY gained. And that in itself doesn't yet tell us whether or not funding the treatment will increase the health of the population or decrease the health of the population. We can't interpret this without knowing what the true value of a QALY is, or and I'll explain more what we mean by the true threshold value of a QALY in a moment. If the threshold value is higher than the 30,666, then FOLFIRINOX is cost effective. This means that we will gain more health benefit from funding the therapy than we'll lose by those technologies which can no longer be funded. But if the threshold value is less than the 30,666, then FOLFIRINOX is not cost effective. So the decision rule to assess whether or not the intervention is going to increase the health of the population or decrease the health of the population is fundamentally down to what that threshold value of a QALY is. Which leads me nicely into now discussing some of the issues raised about the use of economic evaluation in decision-making. So I'm going to go through 7 of these issues, one after the other, and then hopefully we can have some time at the end to discuss each of these if you desire so. So numerous articles have suggested that the threshold for cost effectiveness needs to be raised. Now we know that there is no real published threshold for cost effectiveness in Canada, but we also know the Ontario government once said that it was $50,000, so we can guess that it might be around $50,000, that threshold. And there's numerous articles that have suggested, and just show these very briefly, that the cost effectiveness threshold should be going higher and that the $50,000 is no longer appropriate. And so, for example, this comes from a paper published by a medical oncologist in Ottawa who says that Canada's approval is usually contingent on a $50,000 per quality adjusted life year gained. This value unchanged from the 1970s. I don't know why it's unchanged from the 1970s. I don't think we were doing any studies in Canada at that point. But anyway, it's been changed for a long time. And if we adjust this for inflation, then we should be looking at a threshold of $250,000 per quality in the current day. So this is the argument from Dr. Stewart and his colleagues, saying that, you know, the threshold is too low, and it should be almost 5 times as much as what's currently being used. Now, if the budget for healthcare was unlimited, then we can set the threshold at whatever we think it's worth. In other words, we can decide as a society that a unit of health benefit, equivalent years of perfect health, is worth $250,000, because that's how much we're willing to pay. And then what we'll be doing is we'll be setting the budget rather than setting the threshold, because we'd pay for every technology that costs less than $250,000 per quality gained. And that will lead to a massive increase in healthcare expenditure, but would be reflective of society's willingness to pay for health outcomes. Now, in reality, that's not the case. The budget is restricted, it's limited. So we can't just arbitrarily increase the threshold, because arbitrarily increasing the threshold will impact the availability of other technologies and will actually lead to a large reduction in the health of the population rather than an increase in the health of the population. So if the budget is limited, our threshold must reflect what we give up. So in other words, it has to be that the threshold relates to how productive we are at producing health currently within the healthcare system, so that when we take, say, $1 million from what we currently fund, how much health benefit do we lose? Because that's the equivalent impact of funding one new technology. It's going to impact the availability of funding for the current technologies that we fund. So for example, based on the fact we use a $50,000 threshold, if that is truly reflective of the productivity of healthcare, that means for every $50,000 we take from our currently funded healthcare system, we'll lose 1 quality. So therefore, every new technology has to cost less than $50,000 for every quality they gain. Otherwise, we'll put more money into a technology which produces less health benefit than those technologies that we can no longer fund. So if the appropriate threshold is 50,000, funding for fire and NOx increases the overall health of the population. And it's just a simple math equation. For every 1,000 patients treated, we increase the health of the population by 63 qualities. If the threshold is only $20,000, then funding full fire NOx will decrease the overall health of the population. For every 1,000 patients we treat, we decrease the health of the population by 87 qualities. So this is just simply what we mean by cost effectiveness, is does the treatment increase the overall health of the population, or does it decrease the health of the population? Now, if we set the wrong threshold, doesn't matter in what direction we set the wrong threshold, we'll reduce the level of health in the population. If it's too low, in other words, it's say $5,000 per quality, we would not fund some new therapies which would provide more health than currently funded treatments. So we've got to set it, we can't have it too low, because then we're going to deny access to new technologies which would increase the health of the population. And if it's too high, we would fund new therapies which provide less benefits than currently funded treatments. And so we've got to get that right. In either way, the level of health in the population won't reach its potential. And the fundamental purpose of doing an economic evaluation is to tell the decision maker whether or not the new technology will increase or decrease the level of health in the population. And to get that right, we need to know exactly what that threshold is. Now, currently, there is no study estimating the threshold for Canada. And there's been attempts to try and get funding for such a study, but that's not really come to fruition yet. There is evidence from different jurisdictions across the world. Probably most relevant to Canadian setting is the evidence from England and Wales. And the study there estimated the threshold should be around £12,936 per QALY, which is approximately 20,000 Canadian dollars. So significantly lower threshold than is currently used in decision making today. If we wanted to assume a higher threshold for Canada, then we have to assume one of these two occurs. Either we spend more money on healthcare in Canada than is spent per person in England and Wales, which we can look at the data for and find that that isn't so much the case at all. Or Canada's healthcare system must be pretty awful at producing health, because if we're pretty awful at producing health, the threshold will be higher. And so it's paradoxical to think that the more efficient we become at producing health, then the lower the threshold is. The lower we have to have a target for new technologies to meet, because the current technologies we fund are more efficient at producing health than they were previously. So how can we fund more new therapies? Well, there's two ways we can do it. We can spend more on healthcare. That's the simplest way to fund new therapies. Not deny access to current existing therapies by funding new therapies, but by just spending more on healthcare to make new therapies available. Or we can pay less for the healthcare we already fund. Now, a problem with that is a very large proportion of the costs of healthcare is on salaries. And so unless we're willing to cut the salaries for nurses, and very unlikely cut the salaries of doctors, then we're not going to free up those resources to cover new therapies. So just simply in terms of trying to increase the health of the population, the only way we can really do that is not to arbitrarily increase the threshold of the value for a QALY, because that will actually decrease the health of the population, but it's trying to find ways to be more efficient or spending more on the healthcare we currently provide. This doesn't mean I'm going to say that we shouldn't fund new technologies, because I'm going to address other issues as we go along, which makes this more difficult to really follow, but understand that it's more nuanced as well. Now, another issue that's raised is economic evaluation needs to be broader. Currently, economic evaluations typically adopt a healthcare system perspective. In other words, we only measure the costs occurring within the healthcare system, and that's the focus of the CADIF CDA guidelines for economic evaluation in healthcare and most other guidelines across the world relating to actual decision making. People argue that if we adopt a societal perspective, it allows inclusion of different resource impacts of the different treatments or alternative modes of actions that we can have. And many health interventions impact other sectors. They impact policing, they impact education, they impact social care, etc. And adopting the societal perspective allows us to capture all impacts on society. And people have argued that societal perspective puts patients' interests first. And I'll talk about the whole putting patients' interests first in a moment as well. This is a study that we conducted on looking at the cost effectiveness of infant vaccination for rotavirus in Canada. Now, rotavirus is a gastrointestinal disease that impacts people from the age of 0 and 5. Almost every child will get rotavirus at some stage. I have 5 kids. I'm pretty sure all of them had rotavirus. I can't tell you when that was because you have so many other gastrointestinal illnesses, it's hard to know which is which. So we did a study to look at the vaccination with Rototech, one of the vaccination strategies for rotavirus. And you can see here that vaccination increases the cost to the healthcare system, but decreases the cost from a societal perspective. Has very little impact on QALYs because this is a per person vaccinated analysis, which is common for most vaccination strategies. The net impact per person is actually very, very small. From a healthcare system perspective, we would conclude that rotavirus vaccination is not cost effective, but from a societal perspective, the vaccination is dominant. So in other words, it's less expensive and leads to more QALYs. So what does this actually mean if we adopt the societal perspective? If we adopt the societal perspective, we'll conclude that vaccination is cost effective and we'll go ahead and fund that intervention. So what does that actually mean? Well, we know the QALY gain. We can estimate that as a difference between the two treatments. It's a very small gain, less than just over 1/1000th of a QALY, or about 8 hours or so of increased health per person vaccinated. But the incremental healthcare cost is very small, $137. If the threshold value is 50,000, so that's the threshold we commonly use now, for each patient treated, the overall health of the population is going to decline. It's going to decline by 0.0016 QALYs. So that's just the result of the study. It's the incremental health of 0.00113 and the health that's lost because of the extra funding required for the new technology. The productivity gains with the vaccination, that's the societal benefits of the vaccination, is $167. So by adopting the societal perspective, we're going to fund a treatment which is going to reduce the health of the population, and we're saying we're willing to give up 0.016 QALYs for $167 gains in productivity. So adopting a societal perspective doesn't put patients first because the overall health of the population is going to decline. What that actually means is we're going to divert money that goes to healthcare to fund gains in other sectors, in this case, gains in the productivity. So if we adopt the societal perspective, the whole purpose of economic evaluation, which is to see whether or not the intervention is going to increase the health of the population, we deviate away from that. We go away from that fundamental purpose of doing the study. So what does adopting the societal perspective actually mean? Well, it means we are willing to trade away health benefits for benefits in other sectors. So in other words, we're giving up health and basically using our healthcare dollars to fund interventions which lead to improvements in other areas other than health. This leads to a reduction in the overall population health because we're now willing to fund interventions which decrease the health of the population because there's benefits to other sectors. It also means we'll have to reduce the threshold value for technologies to be cost effective because we're actually spending less money on producing health now because some of the healthcare dollars we're spending is actually to try and get benefits in other sectors. And if we reduce the amount of money we're willing to spend on health, the net impact is the threshold value that we would use to make decisions has to be reduced as well. And fundamentally, it means studies no longer address a specific criteria that decision makers are interested in, because the incremental cost per QALY from a societal perspective has no real meaning to a decision maker. It doesn't tell them a specific outcome. In the case when we're using a healthcare system perspective, it gives us the result specifically in terms of does the health of the population increase or decrease. Deviations away from that to adopt a societal perspective means it no longer fundamentally answers that question for decision makers. Now, I'm not saying that societal costs aren't relevant. They're actually very relevant to decision makers. They're interested in those. But what I'd suggest is that if they are of importance to decision makers, they still need to be presented, but they need to be presented in a different format other than doing an economic evaluation from the societal perspective. We still must present results from the healthcare system perspective because that addresses whether or not the impact on the level of health of the population is positive or negative. But we should provide additional information on the impacts to other sectors of decision makers, because these might be other criteria that decision makers are interested in. As I said already, economic evaluation only addresses one criteria: what's the impact on the overall health of the population? If societal costs are relevant to decision makers, then they need to be presented separately so decision makers can consider those as well as the economic evaluation results in respect to their decision. Let's move to issue 3, which is kind of related to this last issue. CDA places a lot of value on patients' involvement and engagement, which is a good thing. It's good to see patients being involved within the HTA process. And economic evaluation can be informed by getting patients' involvement and engagement. Now, Knappe Thavorn at the University of Ottawa has done quite a lot of work recently about engaging patients and caregivers in the design of economic evaluation, recognizing that those patients' lived experience is actually very relevant to make sure that we design the economic model appropriately to capture what the relevant patient outcomes are. Economic evaluations consider all patients equally. So that's maybe where part of the problem comes about whether or not it's seen to put patients first. It considers those patients with a specific disease who might receive the new treatment as equals to those patients with other diseases who may be affected if their potential treatments are not funded or are delayed or are hard to access. So in other words, all patients are considered of equal value. Now, concerns over whether or not economic evaluation puts patients first really relates to the fact that we can't fund all treatments. That's not the fault of those who do economic evaluations. That's the reality of the decisions that have to be made. And so we can't put patients who receive the technologies first without putting those patients with other diseases second. And so what economic evaluation is trying to do is make every patient of equal value. Now, many times I hear that cost effectiveness is blamed for the reason patients are denied effective new treatments. And that's not necessarily the case, or that is not the case. The reason why patients may be denied new effective treatments is simply it's a consequences that decision makers have to make a decision. We can't afford to fund all new technologies. If we fund one technology, then other technologies cannot be funded. And so it isn't the consequence of doing the economic evaluation that a new technology isn't funded. It's the consequences that decision makers have to make a decision is the reason that in some cases a new technology will not be funded. Working with clinical researchers, I'm often teased quite rigorously that economic evaluations require too many assumptions. It's the most common critique of an economic evaluation. Yet all forms of clinical research, if they're going to be used to help facilitate a decision-making and making a decision, will still require a number of assumptions to make sure that we believe the research that's conducted is relevant to the decision that has to be made. So here are some, but not all, of the assumptions you must make when you look at a clinical trial and try and interpret that clinical trial in terms of the decisions facing a decision maker about whether or not a new treatment should be funded. It all relates to the generalizability of the study. Does it measure the things that patients are interested in? Does it measure at the right time? Is the duration of the trial long enough for us to be able to certain that the treatment is effective? These are all the many assumptions that are involved in using a clinical trial in a decision-making context. And now those assumptions aren't often made explicitly. Good practice in economic evaluations, based on the guidelines from 2016, maybe we last updated the guidelines, requires that all assumptions are made transparently and that we test the validity of these through scenario analysis. So the nature of the evidence available to us to model the cost effectiveness of technologies means we can't avoid the need for assumptions. What's important is we actually say what those assumptions are and test their validity. So this is a kind of therapeutic review that I was involved in that looked at interventions for patients with atrial fibrillation. And you can see on the, this is where I'm bad at remembering my right and left, the right-hand side of the slide, the list of assumptions that were made within the economic model. And then within this report, we test each of those assumptions to see what the impact of those on the results of the study. So economic evaluation does require a lot of assumptions. What you need to do is make the best and most relevant assumption available and then test these within the economic model. Now, I mentioned before the most important data within an economic evaluation are the epidemiology and treatment effectiveness. And Carith, I was involved with this with Karen and others, have come up with guidelines specifically about the use of clinical evidence within economic evaluations. In other words, trying to make sure that we use the most appropriate techniques and the most appropriate assumptions about taking the short-term clinical evidence and then using that to model what the impacts of different technologies would be. Fifth issue, how am I doing for time? Still doing okay. I'll hurry up a little bit here. Is economic evaluations lack transparency and are unnecessarily opaque? And I have to say, I've got a bit of sympathy about this, not because it's necessary that economic evaluations are so, but a large number of the studies and the models we see these days actually fall into this category of lacking transparency and unnecessarily opaque. Now, people often refer to health economic models as being black boxes. It's not necessarily the case. I mean, a black box is basically the idea that we take all the inputs into our model and we suddenly come out at the end miraculously with our estimates of outcomes. Now, a black box refers to a device designed to generate outputs without the ability to assess how it works. And economic models shouldn't be that way. They shouldn't be that complex to follow. They are typically based on simple math. If they weren't based on simple math, I wouldn't be able to understand them. So it has to be a fairly simple degree of mathematics involved. We're basically just combining known data through a series of mathematical relationships. And best practices require transparency and validity, not black boxes. And I think part of the problem is that I think those who more recently in developing models have got distracted away from the idea that simplicity is necessary. If you work in the area of software engineering, the best software engineers are those that can code things with the least amount of lines of code with the most transparent way so other people can follow what they've done. I think we need a move towards economic models that represent that type of thinking. There's a terminology in software engineering called proof through obfuscation, which basically means you make something so complicated that no one else can understand it, so they just accept that it's right. That shouldn't be the way that economic evaluations are designed. So, do they inherently rely on economic black boxes? My argument would be no, they shouldn't. Economics is basically just, or economic models are basically just taking the inputs which are developed through best practices requiring full transparency with respect to inputs and assumptions. We combine these through a series of mathematical relationships that need to be transparent and valid, and we come up with the outputs, which are merely a representation of current knowledge. Now, along with Karen and Alex at Carith, sorry, I'm a bit old. I keep saying Carith. I know it's CDA now. It took me the longest time to stop saying Coda, so I'm not sure I'm still going to be alive when I stop saying Carith. But anyway, CDA Carith developed a tool to help those validate economic models. So it's helpful for those who are producers to make sure they build robust but transparent models, and also it's helpful to reviewers and users to identify any potential errors in being able to validate these models. So that's basically our attempt to try and address the issue about the complexity or over-complexity of models that we often see these days. Sixth issue, economic evaluation is unethical and ignores equity concerns. I love being called unethical. I was once talking to the Health Select Committee where one of the other panelists basically told me that I would like all the Chilean miners to die that were basically buried underground at that point, because as an economist, I don't care about anything other than dollars, which was not the nicest thing to be told in front of a bunch of MPs. And so it's really important that we emphasize what the ethical standpoint or perspective of economics is. So a number of papers have addressed this issue. Economic evaluations address only one criteria of relevance to decision makers. Will the overall health of the population increase? So we don't give an answer, we just tell you one thing. Will the health go up or will the health go down? For this criteria to work, it's based on an explicit equity statement, which is a health benefit gain is of equal value regardless of who experiences it. So there's a specific equity statement within economic evaluation. All patients are equal. If decision makers want to take an alternative equity position, they need to make this position explicit. So if there are some patient groups that are more important than others, then decision makers have to make this transparent. And they must therefore address a trade-off between the impact on total health for their equity concerns. Because if you make one patient group of more value than another, then the overall health of the population will decline, one patient group will gain, but everyone else will lose more than that patient group gains. So that's the impact of taking an alternate equity position. Cost effectiveness is based on collective ethics. Now, there's a conflict between individual ethics, the rights of individuals to be able to obtain what they feel is necessary, to that of collective ethics, which is basically the idea is ethical to fund a treatment that will bring less health benefit and alternative use of our healthcare dollars. If we make inefficient choices, in other words, we choose to fund technologies which don't increase the overall health of the population, necessarily, the overall health of the population declines. And so this great quote from Alan Williams from 1992 is still very much alive today, that the idea that costs are unethical is a mistake, because the costs are the adverse consequences upon others of the decisions you make. Every time you make a decision to fund one new technology, there are adverse consequences, impacts on the health of other patients. And therefore, we should be wanting to look at whether or not those adverse consequences are greater than the health benefits that the new technologies would gain. The last issue, good timing, is that the one I probably find the most fun to have to contend with, because I've sat on many committees in terms of making reimbursement recommendations, and hearing decision makers say that's not very helpful. So one of the issues is that economic evaluations are unhelpful decision makers. And the argument is that the conclusions are not helpful. Often the price reduction required for a new technology is so high, that it makes it difficult to achieve through negotiation. Those price reductions could be 98%, could be 99%. This example here, this is a study that I did with people from the Ottawa Heart Institute for canakinumab. Based on our wellness pay threshold of 50,000, a reduction in price of 91% is required. And so decision makers will say that's not very helpful. We can't achieve a price reduction of 91%, which I can understand. It's going to be a very difficult negotiation with the manufacturer to get a price reduction of 91%. However, the results are real. You can't change the results. Saying that the results are unhelpful is pretty unhelpful because we can't do anything about it. It's simple. If you cannot get the necessary price reduction, so in other words, you can't get the 91% price reduction for canakinumab, then funding the new technology means the overall health of the population will decline. That's just the fact of the matter in terms of telling you what the price reduction you need to obtain. All we're saying is to get the technology being such that the health of the population will not decline if you fund this technology, you need to get a price reduction of 91%. Now, the results are probably unhelpful to decision makers because they want to fund the technology despite its impact on the health of the population. So what we're saying, you need to get this price reduction, otherwise the health of the population will decline, is uncomfortable for them because there are other criteria that's important to them. And they haven't made this criteria explicit. But the reason why they're finding the result unhelpful is because they'd like to fund the technology, but they're not going to get this price reduction of 91%. That's because there's other criteria out there that they consider. It might be politics, it might be equity issues, or maybe putting some patients first over others. There may be constant variety of other criteria that might be important to decision makers. But if they don't make this explicit, it's very hard then for them to come up with a rationale for making one decision over another. And that's why the economic evaluation results are seen to be unhelpful, because they don't validate their initial prejudice about which decision they wish to make. Now, someone with the same name as me 32 years ago, because it couldn't possibly be me who wrote this, actually addressed the whole issue about the impacts of economic evaluations on healthcare decision-making. And what we found then, and it's still valid today, it was me after all, I was 12 at the time, that economic evaluations really have a legitimizing role. If they give the result that the treatment is cost-effective and will increase the health of the population, then decision makers like them. And if the decision maker doesn't want to fund the technology, then they blame the economics for that decision because it's not cost-effective. But the economic evaluation is not a decision rule. There are so many other important pieces of information of relevance to decision makers. And the problem right now is that the economic evaluation is the only criteria that's explicit. Does the health increase or does the health decrease? And if the decision makers reject funding, it's not just because the economics are not favorable, it's because by considering all the other criteria that they're interested in, they don't compensate for it not being cost effective. And in some situations, they will compensate for the technology not being cost effective, and they'll decide to fund the technology. The issue is these other criteria aren't explicitly actually developed or addressed. So final messages before questions. Much of the problem with economic evaluation is a terminology that we use. We use terminology like cost effectiveness and opportunity cost, which seems to imply that all we're worried about is dollars and how much we're spending. But in reality, the economic evaluation is basically a tool to see whether or not the intervention will increase or decrease the health of the population. So it's population health maximization analysis is kind of what we're doing. We're looking to see whether or not the health of the population will increase or decrease if you fund this new technology. The willingness to pay for health benefit is also misleading because it seems to imply that we could just increase it to any value that we'd like, but it should reflect what we give up if we divert resources away from current care, delays to current treatments, or other current treatments just not being available. But the marginal productivity of healthcare isn't really a particularly better way of describing that in terms of people's understanding. But it's not about how much we value a health benefit, it's how much we'd have to give up if we fund resources elsewhere. So key messages. Economics is not about costs, but trying to meet one of many social objectives. Will funding the intervention increase the health of the population? It's based on a collective ethics basis that we're trying to look at the impact of everybody involved. So the health of all individuals is considered of equal value. And most importantly, and I can't really hit this home more, economic evaluation does not provide an answer. I don't think that the only criteria of importance to a decision maker should be whether or not an intervention will increase the health of the population or not. There will be other criteria of relevance and of importance. And what we really need to do is spend more time at identifying what those criteria are and methods for evaluating those criteria as well. Some final thoughts for CDA, given the fact that I'm now retired and I can say you should do this and not have any impacts on me for saying so. Carith has been at the forefront of developing the methodology for economic evaluation. So Karen and her team have done great work at advancing the science and making sure that the Canadian standards for economic evaluation are some of the highest, if not the highest, across the world. I hope this remains a focus for CDA, that we still put money and resources into developing methodologies and making sure the technologies and the methodologies we adopt have got some form of theoretical basis to it, that we're actually still addressing specific criteria of importance to decision makers. I think HTA needs to be more reflective of marginalized communities. We spend a lot of effort at trying to find new interventions for people of middle class and upper class standing. Every time I walk to my exercise class on a Saturday morning, I walk by a large community of homeless individuals. We don't spend enough time trying to think about the social care and healthcare there, and we need to think more about marginalized community. That leads to my third point, which I think is also relevant in this context, is we need to divert focus away from solely evaluating for-profit healthcare. We spend so much time evaluating new high-tech devices and new pharmaceuticals and spend little time on evaluating new methods for delivery of care in which no one's actually making a profit from. So it's a profit-driven research. I think we should spend a little bit more time thinking about how to enhance care for individuals, even when someone isn't making a profit from it. And finally, which I've sort of mentioned a few times, we need to invest more time in determining what other criteria matter to decision makers, other than just increasing the health of the population. That's all, as an economist, our studies tell you. It's not the only thing of relevance. Clearly, there are other things that decision makers are interested in, and it would be helpful for the HTA process that we actually determine what those criteria are. So we're going to make changes to the HTA process that reflect what the true criteria of importance decision makers are. Thank you very much.
Great. Thank you very much, Doug. That was a great presentation. So we're a little low on time, but we do have a couple of minutes for some questions. For those of you in the room, if you do have a question, if you could raise your hand and use the speaker when posing your question. For those online, if you could use the QA tab in the Zoom control bar, and a reminder just to introduce yourself before asking any questions. Maybe while I give folks in the room a moment, we'll check with Bernice to see if there's any questions online.
Yep, certainly. I'll ask the first question. I'll pass it back to in person. So a question from Dan Allender from ICER. So the publication from York attempted to estimate thresholds for different countries based on the relationship between health spending and outcomes and yield a range of 21 to 32K US dollars per quality for Canada. Can you comment on whether that's a reasonable approach?
Thanks, Dan. Hi. I think it's a better approach to what we've done right now, which is just pick an arbitrary number. That number seems to fall in line with the estimates coming from England and Wales for them as a whole. I think it would still be worthwhile to, if we're going to make these decisions and we want to know what the impact of interventions are on the health of the population, that we actually spend the resources to conduct the study specifically for Canada. It seems like the minimum we should do. It's going to be a fraction of the cost of the next drug that Canada recommends for funding. So why not get this right? But I do think that those that range of figures is more reflective of what the likely underlying threshold should be.
Great. Thanks, Dan and Doug. We have a question in the room.
Thanks very much. I'm Rachel Mannion. I'm the Director of System Coordination here at CDA. I have a question. When we think about the kinds of analyses that our colleagues here do so well, we often think about the decision makers being those making decisions about public drug plans. And and yet we have folks in the private drug plan sector that also rely on those analyses. When I was listening to you describe the objective being overall increased health of the population, and I was reflecting on sort of the different roles and objectives of public drug plans versus private drug plans, I was curious if you had any thoughts on whether a different or a tailored approach should be used to answer similar questions for decision makers in private drug plans.
Okay, that's a very good question, because I have done some collaboration with some private payers in evaluating new products, and they have the similar underlying perspective in terms of how they use these studies. They have a different perspective. They're only interested in the cost to the private payer themselves, because that's they're reflective of the budget and the impact of diverting from one way or another. And they're also very reflective, much more than we are, or CARIF or CDA is in terms of the budget impact, because to them, the budget impact is basically the premium that the insured population have to pay towards their health insurance. And so I would say that they're actually adopting the same perspective in terms of cost effectiveness, but they're also more explicitly considering budget impact as a separate criterion in terms of how that impacts in terms of ultimately what would be the necessarily increase in insurance premiums. I mean, it's much easier for them to see the direct impacts than it would be from the Canadian healthcare system, which is so disparate in how it's set up.
Great. Thanks, Rachel. All right. So we're down to our last couple of minutes. And so we'll have to wrap up the question period. Before we go, Doug, I'd like to give you a chance to leave us with any parting thoughts as we wrap up. What do you feel are the most important takeaway messages from your lecture today? Or in other words, if people were only remembering one thing from this talk today, what should it be?
Okay, I think I can give you two things. Don't blame me when new drugs aren't funded, because as health economists, we seem to have a target on our back. All our studies say, I'm going to have to repeat it one more time, is will the new technology increase the health of the population or decrease the health of the population? That's all we can tell you from the studies we conclude. It's just the result of the analysis. We don't make the decisions. We don't set the prices of new technologies. It's just one criteria. And therefore, it doesn't change. You know, you can say you don't like the fact that we consider economics, but ultimately, the health of the population is something that decision makers worry about. And so all our analysis say, will it go up or down? The other real big take-home message is that as an economist, I know that's not the only criteria that decision makers are concerned about. So I don't think it's necessarily the case that that should be the primary or sole criteria. And therefore, I think what we need to have is more dialogue about what those additional criteria are, so that we can more understand the decisions that are being made. We know there are technologies that don't meet the criteria of cost effectiveness. Otherwise, they will not increase the health of the population. They will decrease the health of the population that are funded. And we know there's other technologies that meet the same criteria and they're not funded. So clearly there are other criteria that decision makers use in ultimately coming to decisions. And it would be really helpful if those were identified and processes for evaluating these criteria is developed.
Great, thank you. So this does bring us to the end of today's session. A very big thank you to our guest lecturer, Dr. Doug Coyle, for his talk today. And thanks as well to our in-person as well as our online attendees.